Good morning, everyone. Thank you for joining us this morning. My name is Camilo González Velázquez. I am an associate professor of endocrinology at the Universidad Autónoma de Nuevo León in Monterrey, Mexico, and co-host of this TIRO by MD's webinar series. Today, I'm honored to welcome and introduce today's two wonderful speakers. I will start with Dr. Nydia Burgos, who is an author of the publication we will discuss today on Clinician Agreement on the classification of thyroid nodule ultrasound features. Dr. Burgos trained in medicine in the University of Puerto Rico. She completed internal medicine training in the VA Caribbean healthcare system in San Juan and completed endocrinology, diabetes, and metabolism fellowship in the University of Puerto Rico. She has multiple publications on the field of endocrinology, especially in thyroid nodule assessment. And additionally, I would like to present Dr. Franklin Tessler. Dr. Tessler is emeritus professor in radiology at the University of Alabama in Birmingham. He has authored and co-authored over 70 peer-reviewed scientific papers and commentaries. He's internationally recognized expert in thyroid ultrasound. Dr. Tessler chairs the Committee in Development of the American College of Radiology Thyroid Imaging Reporting and Data System in 2017, which is used to guide the risk stratification and management of thyroid nodules worldwide. He currently leads an international effort to harmonize the recommendations for management of thyroid nodules based on ultrasound. And I'm really honored to present you both with these two wonderful speakers. And with no further ado, I'm going to give the mic to Dr. Burgos.
Hi everyone, thank you so much for the invitation to today's journal club. Today I'm going to be discussing the paper titled Clinician Agreement on the Classification of Thyroid Nodule Ultrasound Features, a survey of 2 endocrine societies. I have nothing to disclose. Now I'll begin with the diagnostic cascade that many of us are familiar with. Often starts off with an incidental finding on another study that thyroid ultrasounds are found, or thyroid nodules found after a specific patient-related complaint. A dedicated thyroid ultrasound is often performed by a sonographer, which is followed by a radiologist that will take a look at these images and look at the different ultrasound features and use the risk stratification system to provide risk stratification of that thyroid nodule. The patient will then have follow-up with his physician, being a primary care physician, endocrinologist, or sometimes patients will go directly to the surgeon. And further determination, looking at the imaging report and looking at the available images, will be done to see if this thyroid nodule warrants further investigation with the FNA biopsy, or if surveillance may be appropriate for the patient. And the reason for this cascade is to answer the question of, is this nodule likely thyroid cancer or not? So ultrasound provides an excellent risk stratification method that is cost effective, and in the past years multiple risk stratification systems have searched to help individualize patient care of thyroid nodules through these validated systems that can help us standardize the risk assessment and personalize patient care and response to thyroid cancer risk, and overall improve communication between the different providers that are involved in the care of patients with thyroid nodules. However, when we take a dive into the existing literature, it's important that when we look at these risk stratification systems to understand and to evaluate the inter-rater or inter-observer agreement in order for these systems to be valuable in our day-to-day practice. So in the existing literature, usually the evaluators that are looking at the thyroid nodules and determining different compositions and echogenicity and all these different features, usually they are radiologists, usually they are classified as very well trained, expert level, and these studies, they evaluate large numbers of thyroid nodules and have statistics done to evaluate inter-rater agreement. Existing meta-analysis that have looked into these inter-rater agreement of TI-RADS in the past have found moderate agreement between evaluators. And this actually reflects kind of an ideal scenario where the evaluators are very well trained, the imaging is very homogeneous, and evaluators have similar scenarios in the type of imaging they are seeing, and for them to provide their response for the TI-RADS. However, as we described in the diagnostic cascade in the beginning, clinicians also play an important role in the determination of thyroid nodule biopsy or decision for surveillance. However, when we look in the literature, there isn't much evaluating inter-rater agreement among clinicians in the literature. So that's kind of where the beginning of our study is formed, and what we really wanted to do in our study was to evaluate inter-rater agreement in the interpretation of thyroid nodule ultrasound features in a large and diverse sample of clinicians. So we performed a survey study. We invited members of the Endocrine Society and the Latin American Thyroid Society, which member base is largely endocrinologists. However, other specialties such as surgeons and radiologists and others are also members. The responders were provided with initial demographic questions, and then they were provided with 10 thyroid nodule cases. There were 3 images per case that they were going to evaluate per ACR TI-RADS criteria. And as I mentioned, the participants in this survey were mostly endocrinologists and some radiologists and other specialties as well. So before we take a deeper dive into the results, it's important that when we talk about the prior studies that were usually well-trained radiologists and we had information regarding inter-rater agreement, usually these studies are analyzed with the kappa statistics. However, it's important to note that kappa has the limitation of the kappa paradox, in which there is high agreement but low reliability coefficient. So for that reason, we decided to use the GWET statistics or the AC1 statistics, as it is quote-unquote kappa paradox resistant in order to provide the information between inter-observer agreement for our study. We also performed a subgroup analysis based on the number of thyroid nodules that were appraised monthly, the responders' preferred ultrasound stratification system, and type of practice as well. Participants that completed less than 40% of the survey were excluded, and because the ACR TI-RADS was calculated from the responses, those who didn't answer each feature response were not included for the analysis, as ACR TI-RADS could not be calculated for those cases. So we received 250 responses. 150 responses in the advertisement of the e-newsletter of the Endocrine Society, and 100 participants from the Latin American Thyroid Society, which was about 23% of the responses. 7 of the participants did not evaluate patients with thyroid nodules, and 99 started the survey but completed less than 40, so these were not included for the analysis. And in the end, we ended up with 144 participants that were included for the analysis, 82 from the Endocrine Society and 62 from the Latin American Thyroid Society. Now, when we take a look and see who responded, there was a slight predominance of the age group greater than 55. The most part of our survey responders were endocrinologists. Some focused on thyroid nodules and cancer, and the other half practicing general endocrinology, but other specialties were also present. However, endocrinologists were the majority. And the main type of practice was also private practice. Now, when we look at the results, we take a look at the level of agreement among participants for thyroid ultrasound features. But first, it's important to define what would be an adequate response or an adequate level of agreement for these features. So, based on benchmark guidelines that previously exist for kappa, we used 0.6 as that threshold between moderate to substantial or moderate or good agreement. So when we look at the individual characteristics or the individual ultrasound features, we see that they fall below the 0.6 mark. Mostly echogenicity and margins were the lowest level of agreement between the ultrasound features. For the echogenic foci, in the survey, the participants had to respond if they were present or not, whereas for composition, echogenicity, shape, and margins, they would describe it per the ACR TI-RADS. When we look at the ACR TI-RADS, we see that it also falls below the 0.6 threshold for substantial agreement. Now, as I mentioned initially, we looked at the preferred system, type of practice, and number of thyroid nodule appraisals per month. And independent of these factors, the level of agreement was low. Now, looking at the level of agreement among participants by case, we see that for 3 cases, the level of agreement was greater than 60%. However, for the remainder of the cases, it was lower than this. So our study shows that there was low agreement for ACR TI-RADS among participants when compared to prior studies. Now, this may be due to various reasons, including participants' background, also our study design, and measures of inter-rater agreement or technical aspects. So this may not necessarily reflect real-world practice. However, thyroid nodule recertification use is not sufficient to guide the care of patients with thyroid nodules if it's not reproducible. And as I mentioned, only in 3 out of 10 cases, more than 60% of the participants would have assigned the same risk category to a particular nodule. So this can result in significant variability on the initial management and recommendations. And I wanted to include this recent study to kind of tie it in with our discussion. This study that came out this year titled Consistency of Thyroid Imaging Reporting and Data System Reporting in Community-Based Imaging Centers versus Large Tertiary Hospital. Here, this research group had a retrospective cohort study done. And basically, thyroid nodules were evaluated at a health maintenance organization imaging center. And at that center, based on TI-RADS, patients were referred for FNA biopsy that was done at a tertiary hospital. At that tertiary hospital, since the FNA was ultrasound guided, they also evaluated the thyroid ultrasound features and determined ACR TI-RADS. And based on their interpretation of the ACR TI-RADS and the score they gave, they would proceed with biopsy or not. So they ended up having 392 nodules identified at the HMO. 22 nodules that were seen at the HMO were not identified at the hospital, and 370 nodules in 336 patients were included for the analysis. And they ended up performing 236 FNA biopsies, and 57 nodules were removed surgically. But the part I want to highlight is that about 1/5 of the nodules were assigned the same TI-RADS by the HMO and the hospital, which is a little low, and the level of agreement they found was poor. About 75% of the nodules had a higher TI-RADS at the HMO compared to the hospital, and they found poor inter-observer agreement in the composition and fair agreement among echogenicity and echogenic foci evaluation. So this kind of ties in with our results that in practice, the inter-rater agreement is actually lower than that has been previously documented in the literature. So it's important to improve inter-rater agreement and ultrasound reader proficiency for a better understanding of the factors that lead to low inter-rater agreement in order to improve practice. So the development of implementation strategies such as education or audit or feedback systems may support a high-quality adoption of thyroid nodule risk stratification to improve the care of our patients with thyroid nodules. So we need to highlight that some of the limitations was the low response rate. These findings in our study may not represent the real world practice. And we were also limited by the 3 images per nodule available, and the participants did not have access to videos that can sometimes be available on usual practice when evaluating thyroid nodules. The survey only included 10 nodules, whereas in prior studies, sometimes hundreds of nodules were evaluated. So those are important features to highlight from our study. But to conclude, in general, we found that the inter-rater agreement of thyroid nodule risk assessment was low, and it was mostly driven by low reproducibility for margins, echogenicity, and shape. Like I mentioned, the only 3 cases, there was agreement of greater than 60% for the thyroid cancer risk category. So this supports the need to support high quality implementation for thyroid nodule risk stratification in practice. Once again, I have nothing to disclose, and I want to thank the THANC Foundation for the invitation and all of our team, including Dr. Brito, Dr. Nike Ospina, and all of our team for the great work that they did on this research study. And once again, thank you, and I look forward to the following discussion.
Okay, first of all, I'm very appreciative of the opportunity to talk to you this morning about this very important subject that's near and dear to my heart as somebody who's worked on risk stratification systems for thyroid nodules for more years than I care to remember. And the drawing that I'm showing here is sort of interesting historically. It's a depiction of the upper airway and thyroid gland over here in front of the airway by Leonardo da Vinci. It's speculated that this drawing was actually of a non-human subject. Nobody will ever know for sure, but he got the appearance roughly right, but he was wrong about the function and purpose of the thyroid gland, which he said was there to fill in space between the muscles and other structures. This is my disclosure slide. So I will be talking in the next few minutes about the paper that you just heard about from Dr. Burgos, Clinician Agreement on Classification of Thyroid Nodules, Ultrasound Features, and the survey that these authors performed. I'll start off talking a little bit about their aim and hypothesis, the methodology that we used, go on to talk about the results and conclusions, and then finish with my take on what we should do next. Starting off with the aim and hypothesis, the aim was to evaluate inter-rater agreement and interpretation of ultrasound features in a large and diverse sample of clinicians. And I applaud these investigators for doing this and for reaching out to a diverse sample as they did, including many people who are out in practice who are non-radiologists who may have different experience with risk stratification systems such as ACR TI-RADS. And their hypothesis was that the inter-rater agreement might be lower because of the variability in imaging training and expertise, among other factors. And I agree with that as well. I heartily concur that agreement in assignment of features and assignment of overall risk levels has been less than we would like. As has been mentioned by Dr. Burgos, one of the limitations here was that there were only 10 nodules. So it's important to know how many instances of each feature were included. It's also important to remember that some features are mutually exclusive, which restricts things a little bit more. This is the ACR TI-RADS chart with the 5 feature categories at the top, and then how they translate by point totals into 5 risk levels. And then at the bottom in the blue area, for each of the 5 categories, some notes. And the reason we did it this way was we thought that this chart would be suitable for posting in places where thyroid nodules were being assessed sonographically, and it would allow for reference during the process. So let's take an example. In these 5 feature categories, there are 18 descriptors. That's a lot to try to sample with only 10 nodules. And as far as saying that some features are mutually exclusive, let's take a nodule that's cystic or almost completely cystic. By definition, it will be anechoic. That's why the anechoic echogenicity feature was put there. It's likely to be wider than tall, also likely to be smooth, and it may or may not have no or large comet tail artifacts. An even more restrictive example is a spongiform nodule. And one of the 10 nodules was spongiform, although the analysis was repeated with the 9 nodules that weren't. But spongiform is an interesting one because I think there's considerable inter-observer variability in when that feature is called. And that's mutually exclusive with all the other categories. If a nodule is spongiform, and that's highlighted here in the composition notes at the bottom, if a nodule is spongiform, it gets no points in other categories, although some people, including Bill Middleton, feel that the presence of calcification, for example, does not preclude a nodule from being spongiform. It's also important to remember, I believe, that some features have more of an influence on the final score than others. And it's especially the 3-point features, taller than wide and punctate echogenic foci, or PEF. So for example, if you have a 2-point nodule without any 3-point features, but you find a 3-point feature, that brings it up to 5 points into the moderately suspicious category, going from no FNA or follow-up to an FNA at a threshold of 1.5 centimeters. So I'd like to spend a little bit of time talking about these 3-point features that I think have an undue influence because of their points. The first being taller than wide. This is from the ACR TI-RADS initial white paper on the lexicon that we developed, showing a transverse sonogram of a nodule. And you can see that the AP measurement is greater than the transverse measurement. But there are a lot of pitfalls to this one. So here's a diagrammatic example of 3 nodules seen on the left in the sagittal view, and here corresponding on the right, what they would look like in the axial plane, going from round to clearly taller than wide to slightly taller than wide. And this illustrates the conundrum of defining what we call shape and deciding whether a nodule is indeed taller than wide. My approach to it is that I rely on my eyeballs rather than the absolute measurements, because it's very easy to move the cursor a millimeter or two and make the nodule technically taller than wide when it may not really deserve that classification. There's also a pitfall related to how the scanning goes. Here's a diagrammatic example of a thyroid gland that dips below toward the mediastinum. I sort of call this the banana thyroid. And depending on how you image this to get the transverse view, it will influence what it looks like in the axial plane. So if you image it like this, orthogonal to the skin, but not to the axis of the thyroid gland, it'll look taller than wide. But if you image it like so, it'll look round and not taller than wide in the axial image. And this is something that would be hard just looking at images to appreciate that this happened during scanning. And that's one of the reasons that the actual scanning procedure is just so important in producing the images and video clips that are used to do the classification. In fact, Giorgio Grani a few years ago published this paper, and suggested a new definition for taller than wide at a ratio of 1.2 instead of 1.0 for the very reason that I just outlined. That is, he and his coworkers felt that by increasing the ratio by a little bit, it would be less likely for this feature to be overcalled and have that influence on the overall score. Another one that is fairly common in my experience is confusing punctate echogenic foci with speckle or microcysts. And here on the left is a thyroid nodule with the arrows pointing out small, somewhat linear echoes that are clearly not punctate echogenic foci. If you look in just about any ultrasound image, the speckle pattern, even in normal thyroid, if you look hard enough, you can hallucinate punctate echogenic foci and thereby add 3 points to a nodule's point total and affect the classification. Here on the right, looking at this video clip, you see multiple linear echogenic lines within this nodule, which I believe do not represent punctate echogenic foci. I think in most cases they're the back walls of cysts. But again, this emphasizes the need to carefully look at often at many images to decide if a feature is there or not. And Dr. Burgos mentioned the lack of clips in their study, and I understand why they did that. That would be hard to do practically, but I find, and my colleagues at UAB and elsewhere find that having ultrasound clips really assists in deciding whether to call a feature or not. Either that or going in to actually scan the patient. I know radiologists are perhaps infamous for, in many cases, for not scanning. I take the opposite tack, and I often go scan patients if I'm not sure about what to say is there. So the second point about methodology that Dr. Burgos mentioned is that there were only 3 images per nodule. In some cases, that's not a big deal. For example, in this nodule, it's mixed cystic and solid. I think with 3 images, you could do a fairly good job of deciding what features are present or not. But for some cases, more images are needed, and video clips, as I just mentioned, are invaluable as well. And here's an example of 2 nodules here in the transverse plane on the left and the sagittal plane on the right. And I would look at this and just looking at these 2 images, I'd sort of wonder about the margin category. Is this a little bit lobulated or microlobulated? This is one where I would want clips or go scan myself, or certainly more images to be sure. The third point was the primary outcome, which was the risk category inter-rater agreement. Although I certainly concur that that's important because it's the risk category that's going to determine management, it's really, in my mind, all about the ultrasound features that produce the risk category. So let me show you an example. Here on the left is a transverse sonogram of a left thyroid nodule, which I will tell you, because it's not included on these images, it's 2 centimeters exactly in maximum diameter. So how would you score this in the ACR system? I think most would agree it's solid or almost completely solid, that it's hyperechoic, or certainly not isoechoic, but people will sometimes perseverate over which of those 2 echogenicity categories to apply, and my response is, doesn't matter, they both get the same 1 point. It has a wider than tall shape, again, even just eyeballing it, and I'd say the margin is smooth and there are no echogenic foci. So adding up the points, you get 3, so this would be a TR3 nodule. In the ATA system, here's the ATA chart. Although the ATA is based on patterns, each of those patterns really just represents a constellation of features. It's not as if in most cases you look at a nodule and instantly know what pattern applies. You really, especially as you get to the higher suspicion levels, you have to look at the individual features and see which one applies. And in this case, I think most would agree that this is hyperechoic. It's solid with a regular margin corresponding to smooth and ACR TI-RADS and would be classed as low suspicion. Let's look at K TI-RADS. This is from the 2021 version of TI-RADS. And again, this would be classified as low suspicion. It's iso or hyperechoic without any of the three suspicious ultrasound features. That is PEF, non-parallel orientation, which is their term for taller than wide, or regular margin. And finally, what about EU TI-RADS? Again, no features of high suspicion in this one. It would be classified as low risk. If you compare the scores, risk, and management for the systems I just showed, in ACR TI-RADS, it's a TR3 and would be followed up in 1 year. ATA would be FNA'd. Under EU TI-RADS, no FNA with a caveat I'll mention in a moment, and K-TI-RADS, same thing. So the malignancy risks are really pretty similar amongst these four predominant systems. The difference in management is really a little more subtle than might be otherwise appreciated, because the FNA threshold in EU TI-RADS and K-TI-RADS is exactly 2 centimeters. It has to be greater than 2 centimeters. So given that this nodule is exactly 2 centimeters, if you breathed on the cursor a little bit and made it 2.1, it would have been FNA'd under EU TI-RADS or K-TI-RADS. And that's a conundrum I think we all deal with in evaluating thyroid nodules if a nodule diameter is just at the threshold for FNA. I've mentioned this in a previous discussion, THANC Foundation, and won't mention it again. I believe that these systems are more similar than they are different. And here's an example of the ATA chart. And if you compare that directly to ACR TI-RADS, they're fully concordant in all these 7 categories. They're really close with only an FNA difference of a ½ centimeter in these 3. There's a greater difference of 1 centimeter in FNA threshold for these. And these last ones where FNA would not be performed in ACR TI-RADS, there would be consideration of FNA and ACR in the ATA guidelines at this threshold of 2 centimeters. Now, differing size thresholds have been brought up by other investigators. This is another paper by Dr. Grani and coworkers, and they looked at these 5 systems and emphasized the difference in FNA threshold between them. And that accounts for a lot of the difference in management recommendations. Even within the Korean Society of Thyroid Radiology and KTA guidelines, there's been a shift over time. These are their 2016 guidelines, and these are their 2021 revised guidelines. And I'll highlight in the last column the 2016 guidelines are thresholds for biopsy. And you see they've actually changed. They've gone up in some of these thresholds, recognizing that the differences between these systems are largely related to the size at which a nodule gets FNA'd, and also based on other research showing that the various systems can be brought more into alignment by adopting similar size thresholds. So the results and conclusions of this paper I completely agree with. Among non-radiology specialties, the inter-rater agreement for risk assessment was low, and I think there's much room for improvement here. So what do we do about that is my last subtopic. And as has been mentioned before, there are many risk stratification systems out there. This is just a sampling of them, and notably, no fewer than 77 of them are called TI-RADS. The first one being proposed by Eleonora Horvath and co-workers back in 2009, and the most recent one, the 2021 revision of K-TI-RADS. So there are a lot of these, and they cause problems. First of all, I think this leads to confusion for practitioners and for patients, because sometimes we've seen reports that have both systems classifying a nodule somewhat differently. There is a lot of effort worldwide, duplication of effort in updating these multiple systems by people who have don't have are giving of their time to do this. So there's a lot of effort going on around the world that is really duplicated. And finally, this makes the multiplicity of systems makes it difficult to compare study results. I'm not going to really talk about it here much, but we published earlier this year an international survey that several of us did, looking at what people thought about risk stratification systems. And in many cases, there were more than one system was being used just in a single practice. In late 2017, I approached the lead authors of several of the papers that presented risk stratification systems and said, this is sort of crazy. Would you like to work together? And I expected them to say, well, you're crazy. The answer is no, but they were very receptive. And that led to the development of a steering committee representing professional organizations that developed and published risk stratification systems or guidelines, either singly or collaboratively. And these are all shown here. And we've tentatively called the system that we're developing I-TI-RADS, I for international. Phase one being to develop a universal lexicon and an online atlas. I'll mention more about the atlas in a moment because I think that's critical. Phase two, which is about to get underway, is to take the lexicon and create a risk stratification system based on it. What we are going to try to do is avoid the conundrum of how you translate a given set of features into a risk category, whether it's points or patterns or something in between, and apply all three at the same time at the person who's using the system at their discretion to get, it's the final result that will matter as long as they choose the features correctly. And of course, there will always be a need to modify the risk stratification by other factors, including nodule location, which has been shown. This is what was presented and discussed at the last time I presented, epidemiology, patient's age, and so on. So the online atlas is critical to this, and I think that this is going to make a big difference in terms of training. And the goal is to make this internationally available at no cost. It'll include four components. Of course, still images, lots of them, that illustrate what each descriptor, another word for feature, should look like. We are also going to include many drawings that will be used to highlight the salient points of individual features. Sometimes if you point to something in just a static ultrasound image, it's harder to get the idea across. So we're going to include drawings. We're also going to include many video clips because, as I mentioned earlier, it's the next best thing to going in to scan yourself. And sometimes a nodule that looks to have one echogenicity from a certain perspective will appear slightly different from another. So video clips are important. And here, the most important thing, I think, and this is the same clip I showed before with the punctate echogenic foci that I believe are not PEFs, we are going to have examples of mimics. So in this example, we would say, this is not what a punctate echogenic focus should look like. We are currently soliciting examples for this now. Where this effort is the lexicon has been finished. It was developed through a modified Delphi process over the past year or two. The paper that will present it is just about complete. We have a writing group of 6 people, and of course, writing by committee is always an interesting exercise. I just released the draft to the writing committee, who've already commented on previous drafts, and expect to hear back from them in the next few days. What we're going to do after that is present the manuscript to the other people who weren't on the writing committee, but who were part of the modified Delphi voting process. We have tentative commitment from a couple of journals to publish this simultaneously when we're ready. because I think getting buy-in to this is going to be important. I was asked earlier how this relates to the other risk stratification systems around the world that are being in the process of being revised, whether it's the ATA guidelines or ETA or ACR TI-RADS. And there is a lot of overlap in personnel between the people doing those things and the people in this group. The people in the steering committee and the other people who participated who are not in the steering committee, who are from around the world, although this has been going on for more than 4 years, remain incredibly enthusiastic about this effort, which is, I'm very pleased to see. I think they all realize, because they've all been involved in developing risk stratification systems, that this is an important thing to do, and that at least eliminating the duplication of effort will be valuable. So again, this is my disclosure slide, and thanks for your attention. And yeah, that is a deliberate misspelling on my part. Again, I appreciate the opportunity to be here today and look forward to answering any questions.
Thank you so much, Dr. Tessler, for this very thought-provoking presentation. I myself have many questions to ask. I think this is a very interesting topic, and I do want to ask the attendees to share their questions through the Q&A function so we can share this with the presenters. So I'm going to go ahead, and I want to ask Nydia a couple of questions about the study. And I know you presented the proportion of participants in your study, and some of them were obtained by the Endocrine Society letter, and some of them were from the Latin American Society. Do you have a geographic distribution of how this came about?
In terms of the respondents, you mean?
Correct, yeah.
Yeah, so our distribution was mainly US and Latin America. The responders from other parts of the world in Europe were much lower.
Thank you. I was wondering, as I was listening to Dr. Franklin Tessler's presentation, he was mentioning that there's some caveats on how you assess a specific feature, and some of these are based on how you do it, and the how you do it is very different. And I don't mean to. What I want to say is not based on what classification you use, but the how to do an ultrasound might be different in different places, and the how to can include like what equipment you used, where you were trained. There's many questions in the how you did that. So as you know, there's certain countries, for example in Latin America, you might have a report bias, if you could call it that, on where where the respondents were. So I'm guessing that as there are some countries, or there are some places, as we all know, like many of the thyroid ultrasounds that are done currently, many of them are done in the communities, like not in academic centers. So I'm wondering if there's anything based on the geography or the distribution of where these participants were, if you think that brings a little bit of bias into the results that you presented.
Well, in terms of the images that were provided in the survey, they were all obtained from an academic center, and those were the ones that were included in the survey. But yeah, you bring an important point that maybe the responders have an unacknowledged bias when answering the questions due to that.
You were mentioning the three images problem that was brought into this study, and Dr. Tessler made brought in to the table the conundrum or the difficulty of evaluating a certain feature. For example, he spoke about Dr. Granny's study where they proposed a different cutoff value for the taller than wide feature. So Dr. Granny said more than 1.2. Give us your thought, Dr. Tessler, on what do we do between 1.0 and 1.2? Is that like a different point that you would give to that patient, or what do you think we should do moving forward?
As I said during my presentation, I actually do not rely on absolute measurements because I think there is so much variability. Unless a nodule is so perfectly defined and the interface with normal thyroid is so clear that you can unequivocally place the cursor where at that interface, I personally don't call the that feature unless it's really obvious. I would probably lean more toward what Dr. Grani suggests without using an actual ratio, and that sounds very subjective and non-scientific, which it is, and it highlights the point that ultimately we're this is being processed through human eyes and brains. And that brings up a point I didn't go into, but that I think is important. I think there is going to be a tremendous effect of radiomics and AI related techniques over the next few years in reducing inter-observer variability. When you put the machine into the equation, I'm working with a co-author on a review of AI in thyroid gland assessments for one of the journals that hopefully will get published later this year. And if for those of you who've been following this train of literature, even superficially, the number of articles has just blossomed over the last few years. If you do a PubMed search on thyroid AI, you'll come up with hundreds of thousands of articles. That doesn't mean that AI is going to be the be all and end all and reduce the need for humans, but I think it will make a tremendous improvement because machines are nothing if not consistent in their evaluation of images, and the science of radiomics really involves extraction of features from images that we as humans can't discern, rather than looking at the specific features that we outline in any of the risk stratification systems. So I think that's going to make a big difference. The key is going to be how to implement those systems in practice. I think they have to be easy to use. They need to be either built into the ultrasound equipment, as has already happened for some of them, and or built into the workstations where the images are being reviewed.
Right. Dr. Burgos was mentioning those features that have the lowest concordance or the reproducibility between observers, and she mentioned margins, echogenicity, and shape. When I think about the presentation that you gave us with the 3-point features where you have the greatest change in where these nodules are upstaged, we could say that. What do you think about how do we solve that problem, and how did the ACR TI-RADS come about giving them so many points when we go back to the data that we were just presented? Those seem to be the ones with the highest difference between observers.
Yeah, shape is a big one, and we didn't. One could argue that we should have done the type of study Dr. Burgos showed to validate what we were doing and say, well, if something's a 3-point feature, for example, but it has very low agreement between people, should we give it fewer points, or what should we do about it? A point I also didn't mention about the international system is that we are going to, we also plan to do this type of study with many many nodules to evaluate our lexicon that will be hopefully published later this year. But I think it's important to say shape. Like I said, I rely on eyeballing it rather than measurements. Echogenicity and margin are interesting. Margin, I think we made the mistake of not being a little bit vague in ACR TI-RADS about what represents an irregular lobulated margin, because some people, and there was a recent paper that came out, I think it was published, it was either in JUM or Thyroid, I don't remember which, but it looked at more closely at what constitutes a lobulated or microlobulated margin. And what they showed was that, and Dr. Maitre Patel was one of the authors of this, and I've talked about this paper with him. He showed that nodules that have sort of macrolobulation, this sort of rounded protrusions, probably should not be called get that lobulated or irregular feature in ACR TI-RADS. And they showed that the size of the base of the lobulation is important. If it's bigger than a certain amount, then you probably shouldn't call it. And I think that's a source of confusion. And it speaks to what Dr. Burgos said about we all collectively need to do a much better job at educating and showing what each feature is and what each feature is not. And that's where this atlas is going to come in. Echogenicity is another interesting one. You'd think that would be as they say, a no-brainer, but those of you who've actually scanned know that you change either whether it's the incidentating frequency or come at the nodule from a slightly different angle, the nodule that looked, say, isoechoic compared to the rest of the thyroid suddenly looks either more echogenic, which is not a big deal because it's the same points, but even couldn't look hypoechoic. So again, emphasizing the need to look at nodules from multiple perspectives and emphasizing the technical points will be really important.
I apologize, I was muted. I wanted to ask Nydia one quick question. How did you go about selecting these nodules specifically? I would have found really interesting if we would have had one of those like unclassifiable, if we could call them that, nodules, where you have, like, for example, a continuous outer calcification when you get a shadow and you can't really make a call on all the features of a thyroid nodule. Would you think that would have muddied the waters a little bit more, made the discordance between observers even bigger?
Yeah. Well, you bring an important point. As Dr. Tessler said, 10 nodules is a very limited space to present all these different ultrasound features. So the way we did it about our study was that a panel of experts reviewed the imaging available and tried to select images that would reflect all the ultrasound features. That was a little bit difficult to include in the 10 nodules. And also, it's important to point out that when you try to display all the features, you're also showing maybe more complex nodules than you're actually showing in day-to-day practice. So yeah, it was definitely a challenge in picking which 10 nodules to include for the study. And definitely including a non-classifiable nodule would have made it even more complicated.
Right. Dr. Tessler, you brought the artificial intelligence issue into the table, and I wanted to ask you, a couple of weeks back we had, well, at the very beginning when we started this webinar series, we had Dr. Johnson Thomas present the APX project, where he has a very interesting take on the use of artificial intelligence into thyroid nodule classification. They don't have a black box system, but they rather have a precision in loop where we kind of tweak the response that we get from that dichotomic or that output that the system might give us. So what do you think? Are we teaching it to be better, or are we teaching it to have kind of the same bias that we're having, being that we have the physician in loop?
Yeah, Bob, I don't know the answer to that for sure. And full disclosure, and speaking of which, I'm a consultant with AIBX, and I know Johnson well. And in fact, he's the co-author I referred to earlier, writing this review article with me. And we talk about this a lot. I don't think we know yet. The promise AI has followed, like most technologies, it's followed what Gartner, which is a well-known research company, calls the hype cycle, where something is discovered and the curve goes way up. Hey, this is going to be the answer to everything. And then it comes back down to reality, and where the technology, whatever it happens to be, we find out how it works in the real world and find that it's not quite as wonderful as originally suspected, but still makes a real difference. In fact, some years ago, a well-known researcher made a statement before a radiology meeting where he said that, talking about the US, we should stop training radiologists because they're all going to be replaced by AI. And as you might guess, that caused a little bit of an uproar. He dialed that back subsequently. I don't know if you received threats of having barium thrown at his house from radiologists or something like that. But that's not going to happen. I see the role of AI is augmenting what humans do rather than replacing. It's possible in 100 or 200 years that it'll do more. But for example, in the area of imaging, where AI has really begun to make its mark, it's really alerting physicians to things that they otherwise might have missed, as much as rather than taking over the entire diagnostic pathway. And that's where I think it's going to have at least initially, its major effect.
Okay, so two questions. The first one is, do you think from what we get from those systems, because I think it's a little bit of a big leap to go from what we have right now to classify a thyroid nodule to go full on artificial intelligence, but do we need to go back and reteach the physician to train their eye so we have a better, less discordance between a classification of a single thyroid nodule?
Well, the practical point is that even if there are only a handful of FDA, at least in the US, FDA approved AI systems for thyroid nodules, there are many more that have been developed by various groups and companies. But I think that it's important to remember that even as these systems are released, they are not going to be available to much of the world of thyroid nodule assessment, just for practical reasons, whether they're as separate software systems or incorporated into scanners. So I think that completely human-based risk stratification will be around for a long time. And that's why one of the things we're trying to do in ACR TI-RADS, the initial release won't include anything about AI, but and that's in recognition of the fact that we want to release a system that is easy to use. Because if it's more complex than what's out there already, what's the point? There's already, as I showed in my slide, there's already enough of these risk stratification systems. There's got to be some compelling reason for people to use it, and we hope that its simplicity will be the carrot that attracts people to it, in addition to the other ancillary advantages, such as reducing the duplication of effort that I spoke about.
Exactly, and that brings me to my next question. I was going to ask you to, if you can, give us a little bit of a teaser of what ACR means. Is it going more granular? Is it going to try to keep it simple so it's more reproducible? Because we started the discussion with, if it's not reproducible, it's probably not useful. So where's ACR going, or can you give us a little bit of a teaser?
Well, sure. As I said, the only thing we've done so far is the lexicon. And the lexicon, as in any international system where you're trying to reconcile the sometimes opposing opinions of people, experts from around the world, there's some of it is a compromise. But what we're trying to do mostly is it's not going to look vastly different from the systems out there in terms of the features. It's not as if we've come up with a feature that nobody ever thought of before that makes a difference in risk stratification. So that's number one. But the other is, I think the biggest advantage of it will be that atlas. Because without the atlas, because if you look at all the risk stratification systems that have been published, they're accompanied by pictures, but I don't think that's enough. And as I also mentioned, showing what a feature is not is at least as important as showing what a feature is. And that's a core principle of what we're going to do in the ACR TI-RADS Atlas. I don't know if that answered your question.
Yeah, that's a great response. And one last question, and I really hope we had like one more hour to speak about this, but what happens when with the classification systems, when you have thyroid nodule there, you're having difficulty to classify, and you look a little bit to the side and you find a lymph node that is classically or very, very appealing or very suspicious. I understand that TIRO was made to classify a thyroid nodule, but in the intent to give next steps to a patient or to drive their treatment, when you find a lymph node that is clearly suspicious, I think there should be like a thyroid 6. Like, forget about has it punctated echogenic phosphate. Like, look at the lymph node.
Yes, and that of course is something that was not included in ACR TI-RADS and is included in systems like the ATA guidelines. TI-RADS does have a category for lymph nodes. I'll say that much, because I agree with you. Sometimes the lymph node is the only visible indication that there is a papillary thyroid carcinoma sitting somewhere in the thyroid gland. So I agree with you.
Thank you so much. So we are almost at the 9 o'clock hour. I want to thank you both for very, very incredible presentations. I want to invite you all to come back next Friday, where we will have another session for TIRO MD's webinar series. We'll have a session on long-term efficacy of ethanol ablation and treatment in metastatic lymph nodes and papillary thyroid carcinoma. So thank you all. Have a great weekend. Stay safe.